I will hand it off over to our first presenter, Anna Nguyen, to get us started.
Thank you so much, Geraldine, for kicking us off today. I just wanted to welcome everyone again. Good afternoon. Welcome to the Silos to Synergy, Transforming Child Welfare Health Through Partnerships with Managed Care Plans. My name is Anna Nguyen, and I'm a Staff Services Manager 1 of the Early Childhood and Health Systems Integration Unit at the California Department of Social Services, or CDSS. And we have had the pleasure of partnering with the Department of Healthcare Services, or DHCS, on policies on Medi-Cal for the child welfare population. So happy to be here today. And we are going to be discussing the delivery system overview, Medi-Cal fee-for-service versus managed care. We'll also take a look at child welfare memoranda of understandings, or MOUs. We'll look at the purpose and components of those MOUs, and then state guidance and expectations. We'll also take a look at best practices for MOU negotiation, again, a joint presentation from the local child welfare agency and managed care plans, and strategies for successful collaboration and implementation. We will look at the review of the Managed Care Plan Child Welfare Liaison, or the CWL role, responsibilities and expectations of the CWL, integration with the child welfare systems, and end with local perspectives, interaction with the Child Welfare Liaison. Got a presentation from the local child welfare agencies, and an insider scoop on experiences, challenges, and opportunities that come with this work. So we have a lot in store today, and I'm excited for our presenters. So I will pass it on to Amara from DHCS to take us to the next slide.
All right, thank you, Anna. We can move to the next slide. With that, my name is Amara Baharami-Arif, and I'm the branch chief in the Managed Care Policy branch at the Department of Healthcare Services. It's a pleasure to be here today. My team actually led the development of the MOU policy and the MOU templates and the monitoring that we do for our managed care plans. This is a true example of collaboration and partnership sort of at the state and at the local level. And so really just appreciate everyone being here today and really appreciate the presenters that have volunteered to present at this wonderful event that we've been planning for a while. So really appreciate the opportunity and look forward to sharing a little bit more about the Medi-Cal delivery system and the MOU templates and policy that my team helped lead. So to kick us off today, we're going to talk a little bit about the Medi-Cal delivery system. Since most of our presentation today is focused on managed care, we wanted to just kind of set the stage with the difference between fee-for-service and managed care. For those of you that have been working in the Medi-Cal space for a while, you may know fee-for-service more commonly referred to as straight Medi-Cal. So this slide is really just intended to sort of outline the differences between fee-for-service and managed care, as we do have members that are in both delivery systems, and we'll talk a little bit more about that on a future slide. So in fee-for-service, members can visit any Medi-Cal enrolled provider who accepts Medi-Cal and has availability to accept a new patient. The providers ultimately submit the claims directly to the Department of Healthcare Services to adjudicate, and then the Department of Healthcare Services ultimately reimburses those providers directly. Versus in managed care, ultimately DHCS directly contracts with managed care plans, and we have some of those partners on the call today. So Kaiser Permanente and also HealthNet are some really good examples to provide access to a network of Medi-Cal providers. These members access healthcare services through their plans networks of physicians, hospitals, clinics, and ultimately we, the Department of Healthcare Services, pay those managed care plans a fixed per member per month fee, which we refer to as a capitated rate. Members select their MCPs and their primary care physician with the help and support of their managed care plan. And then the Department of Healthcare Services conducts monitoring and various oversight mechanisms on those managed care plans. With that, we can go to the next slide. Next slide, please. All right, perfect, thank you. So this slide just really kind of shows the differences sort of from a member perspective for what's available for a member that's enrolled in fee-for-service versus managed care. So when you look at provider choice from a member perspective, there are a lot of similarities, However, the differences are really where I'm going to focus and highlight on. So as sort of referenced in the previous slide, a member in fee-for-service can select any Medi-Cal enrolled provider versus those enrolled in managed care would be really focused on those providers within the managed care network. In both fee-for-service and managed care, there's assistance with finding providers and also making appointments and arranging for transportation. When we refer to continuity of care, so if a member is moving from county to county, in fee-for-service, there's no continuity of care requirements versus in managed care, we do have continuity of care requirements when they transition from plan to plan. There is some differences with care management. So the Department of Healthcare Services has worked on a really robust population health management program in the managed care space to really offer tiered care coordination, which many of you probably heard, enhanced care management. We also have the managed care child welfare liaison, which you'll hear a little bit more about. And those services are not currently available in the fee-for-service environment. We've also been doing a lot of work with CalAIN tied to community supports. So currently, the department offers up to 15 community supports that are available sort of throughout the state, and the managed care plans have the option to elect which managed care community supports they offer, except for transitional rent, which is a statewide benefit that just became effective January 1st, 2026. Those community supports are not available in the fee-for-service environment currently. And then when you look at it from due process perspective, both fee-for-service and managed care enrollees have access to state fair hearings. However, in the managed care space, they do have a few more rights, so they can submit grievances and appeals directly to the managed care plan. And if those are not resolved at the managed care level, then they have the right to move forward with the state fair hearing. So this is really kind of intended to just sort of showcase some of the differences between the different Medi-Cal delivery systems. All right, with that, we can go to the next slide, please. All right, thank you. So this is Medi-Cal data from June 2025. So this is really just intending to showcase that we have nearly 95, well, just over 95% of our Medi-Cal members enrolled in that managed care delivery system that I just talked about. And only about less than 5% of those are enrolled in that fee-for-service delivery system. So it equates to about 14 million members that are enrolled in managed care. And if you want to learn a little bit more about Medi-Cal Fast Facts, there is a link sort of embedded in this presentation that will be shared if it hasn't been shared yet, but lots of helpful data there. All right, and then we can go to the next slide. And then this slide is really just intending to highlight that there are different managed care models that are delivered throughout the state, and sort of depending on the different models, there are sort of different enrollment requirements. So we have the county organized health system, also referred to as COES, which is one plan operated by county, two plan, which is one local initiative plan authorized by the county, and one by commercial plan, a single plan, one plan authorized and sponsored by the county, and then what we refer to as GMC and regional models, which is multiple commercial plans, which Sacramento is a really great example of that, which is one of the areas we're going to focus in on today. The map also kind of clearly differentiates by county, sort of which plan model operates where, and there are some nuances in sort of how the managed care models operate in those counties. So just wanted to sort of share a little bit of additional information regarding those managed care models. With that, I'm going to pass it over to Jacqueline Carmara from California Department of Social Services to share a little bit more about the partnership that we've had at the state level.
Thank you, Amara. Hello, everyone. I'm Jacqueline Carmona, analyst in the Early Childhood and Health Systems Integration Unit at CDSS. And you can go ahead and switch to the next slide, please. Thank you. So as you can all see in the slide, we would like to highlight the partnership between CDSS and DHCS to strengthen initiatives for children and youth involved in child welfare. We partnered to develop the MCP Child Welfare Liaison Policy. We also worked together to develop the Child Welfare Memorandum of Understanding template, and we continue to conduct strategic planning to strengthen the child welfare and managed care plan partnerships. Now I'll pass it back to Amara to discuss the Memoranda of Understanding.
Perfect. Thank you. With that, we can skip 2 slides. So we can go to slide 9. We can go to where we showcase the goals of the Memorandum of Understanding, or what we refer to as MOUs. So very helpful sort of initiative poll to kind of kick off and understand sort of the landscape and who is attending the call today. Because it's very interesting, the MOUs are actually a part of a larger set of documents that I'll go into a little bit more that sort of impact other people that participate in systems of care. And so it's good to sort of understand the audience of who's here today. So our Medi-Cal managed care contract, which is ultimately our contract between us and our managed care plans at the Department of Healthcare Services, and what provides guidance to our managed care plans, requires that the managed care plans enter into MOUs with county and third-party partners to contractually ensure the provision of a whole system person-centered care approach. And so some of those third parties include some of the community-based organizations, also behavioral health department at the county level, child welfare agencies, the regional centers. So this is sort of a part of a much larger effort. And so there's a lot of entities that are at play here that expand much larger than just the child welfare agency. So it was good to kind of understand a little bit of the audience of who's here today. So when we started this effort, we did establish some goals with requiring the MOUs. So we really wanted to make sure that we had established minimum requirements for contacts in the MOUs between ultimately those managed care plans and the other party that would be ultimately consistent across all the entities that our managed care partners coordinate with to ensure that members are receiving services. As we're aware, Medi-Cal members, they receive services in many different delivery systems. And so it's really important to ensure that we have that coordinated care. On that same note, it's also equally important to know roles and responsibilities. Who's ultimately responsible for delivering what type of care or service to these Medi-Cal members, including those that are carved out of the Medi-Cal contract. It also aims to establish formal processes for how the parties are going to collaborate and coordinate on population health programs. So as I sort of mentioned, we have moved forward with big initiatives to really implement that population health management approach. And so really these MOUs are intended to really strengthen the relationships at the local level. Also, equally important, data sharing pathways, establishing data sharing pathways between the managed care plans and the other parties. This really serves as some of the core foundation of the MOUs, which really enable that support for care coordination and also robust monitoring. The goals also include oversight and accountability for the MCPs to execute MOUs with other parties. And ultimately, the goals focus on providing transparency, not only between the two parties, but other parties as well, as there is a requirement for the managed care plans to post the executed MOUs on their websites. With that, we can go to the next slide, please. So as I kind of mentioned, the MOUs, the County Child Welfare MOU template is a part of a larger set of documents that the department created to really support that population health management approach that we're taking. And these include our guidance, which are all plan letters that we issue to our managed care plans that really include the base requirements for the MOUs. It sets forth expectations of our managed care plans, such as annual review of the MOU, how they're ultimately I apologize for that, how they're ultimately going to be communicating with the department on how they're executing the MOUs, their current status, if they're having any challenges. It also includes detailed requirements that outline sort of the roles and intent of the MOUs. So that's our all plan letter, which is our guidance to our managed care plans. We also created what we refer to as a base MOU template, which is really sort of a generic template that includes all of the key provisions that are contained in these bespoke templates that are more specific templates. So it was really just sort of the foundation that we used to ensure that we were able to meet some of those goals that I reviewed on the previous slide, to ensure that we did have consistency across all of our MOU templates for how the managed care plans were ultimately operating with that other party. But then we move on to the bespoke template, which in this case is the County Child Welfare MOU template, which really contains some of those more specific requirements for how the parties are engaging and interacting with each other. So it contains the base MOU template and then those more program-specific provisions, including guidance that exists in other places that are really directly tied to the relationship between the managed care plan and the County Child Welfare Agency. We also have included optional provisions that you all may be familiar with that are in italics that are located throughout the MOUs. Links to the MOUs will be shared at a future slide where you can locate all this information if you're already not aware of where to find this information. So we can move to the next slide. So this slide is really intended to just sort of highlight some of the key components of the MOUs. I'm not going to go into this in detail, but these are the requirements that are contained in each of the MOU templates. We have definitions, services, party obligations, training and education, referrals, care coordination, quarterly meetings, data sharing and confidentiality, quality improvement, dispute resolution, equal treatment, and general terms. So these are the base MOU requirements that are contained in all of the bespoke MOU templates. So they're in the regional center MOU template, in our behavioral health MOU template, and also in our child welfare MOU template. With that, we can go to the next slide. And I'm going to actually kick this one back to Jackie.
Thank you, Amara. Awesome. So the County Child Welfare MOU template seeks to improve care coordination between managed care plans and counties by opening channels of communication between managed care plans and counties to coordinate care for children and youth involved with child welfare and to address concerns related to ensuring children and youth get the services they require and to address care coordination. And also enhancing each party's understanding of the other's respective services and operations. For instance, each party should provide training and education resources for their respective services and operations to the other party to increase timely coordination and decrease process inefficiencies. Now I'll pass it on to Amara to discuss the child welfare liaison.
Perfect. Thank you so much. With that, we can go to the next slide. So those of you that may be familiar with the County Child Welfare MOU template, there is a definition section and also requirements that relate to the Child Welfare Liaison, which is included as a requirement for our managed care plans to designate at least one individual to serve as the Child Welfare Liaison to really support with that care coordination for escalated cases that may need additional support. I'm not going to go into a ton of detail on this right now because Kimberly Swift, who was responsible for developing the policy, is going to give us a little bit more detail on this in the future. So I want to make sure that we save some space for that. So with that, we can go to the next slide. Another key area that I mentioned was data sharing and confidentiality. And so this section of the MOU template is really intended to encourage parties to determine and document the minimum necessary information that must be shared to really support referrals and ultimately care coordination for these Medi-Cal members. So those provisions encourage the development of policies and procedures between ultimately the managed care plan and the child welfare liaison to determine how that data will be exchanged and how it will be securely and confidentially shared within applicable state and federal laws. It also outlines requirements that include that the MCPs must share information necessary with county to make sure that the county liaison is aware of members receiving enhanced care management, complex case management, and also community supports. And then there is also some additional guidance related to sharing members' data and information related to the CalAIM data sharing authorization guidance, which is also referenced in the actual MOU template. With that, we can go to the next slide. So care coordination and collaboration is really the next big bucket, which is, ultimately sort of the nuts and bolts of why we're all here today, right? To ensure that members are receiving the care that they need and the different delivery systems in which they may be accessing it. And so the intent of this section is to encourage the parties to development and ultimately document how the parties will coordinate care and then monitor whether those processes are working and then improve processes as necessary. So there are some provisions really tied to the managed care plans. So it includes that the managed care plan and county coordination is to ensure the referral of county mental health plans for specialty mental health service assessments. It also includes the coordination related and required on the managed care plans for what we refer to as Medi-Cal for kids and teens to ensure that they're receiving medically necessary covered services. You may also know that more less commonly referred to as EPSDT. And then it also includes provisions related to the MCP county liaison must oversee coordination of care for members receiving county child welfare services. So really this is focusing on trying to figure out how the parties are going to collaborate and work together to ensure that member care is coordinated. We look forward to hearing a little bit more about this from our local partners further on in the presentation. And with that, I am going to actually pass it over to Anna to provide an update on AB 2083.
Thank you, Amara. All right, perfect. So speaking of care coordination collaboration, an important optional provision of the County Child Welfare MOU is Assembly Bill 2083 or AB 2083. And AB 23 requires each county to develop and implement an MOU setting forth roles and responsibilities of agencies and other entities, such as county child welfare agencies, that serve children and youth in foster care who have experienced severe trauma. The purpose of the AB 2083 MOU is to ensure that children and youth in foster care receive coordinated, timely, and trauma-informed services. And just to be clear, the MOU is not between the MCPs and counties. However, DHCS and CDSS encourage counties and MCPs to consider how their county child welfare MOU may be aligned with their pre-existing AB 2083 MOUs to enhance care coordination and collaboration. And we are good to head to that next slide, please. Perfect. Thank you. Okay. So thus the County Child Welfare MOU template includes the following optional provisions. MCPs must collaborate with county to identify opportunities for coordination and alignment of this MOU with county's interagency leadership team or ILT's efforts in implementing the AB 2083 MOU to increase members' ability to receive timely, coordinated care. County must include MCP as a party to its AB 2083 MOU with local entities to ensure coordination between the MCP, county, and local entities as necessary and applicable to ensure members receive whole person care. These optional provisions are suggested to help the parties consider how they might align the County Child Welfare MOU with care coordination activities set forth in the county's AB 2083 MOU and should be altered by the parties as appropriate to capture their approach to aligning care coordination activities across the MOUs. Alrighty, and then with that, I'm going to pass it back to you, Amara. And we are good to go to that next slide.
Perfect. Thank you so much, Anna. And so I'm here just wanted to share a little bit more. We have created this DHCS website. I'm going to actually drop the link in the chat, which sort of is our one-stop shop for all memoranda of understanding materials. So that includes our all plan letter, which is the guidance to the managed care plan, the bespoke MOU template, so the child welfare MCP MOU template, FAQs that may be really helpful to reference as you're sort of negotiating the MOU. It also contains past webinars that we've hosted. There are a few that were hosted for the child welfare MOU template, so I'd encourage you to check that out. And then we include key updates on our website as they become available as well. We are also happy to help provide any technical assistance as needed. So we have included the MCP MOUs at dhcs.ca.gov email address if questions arise as you sort of work through the process. So we appreciate that. And with that, we will go to the next slide. Right, thank you. I'm going to be presenting this in partnership with Anna, since this entire effort really has been a partnership. So with that, I'm going to cover sort of the MCP perspective, and then I'll pass it over to Anna. So to cover MCP MOU execution and next steps, our managed care partners are continuing to reach out and form those relationships with the counties, and they're holding discussions regarding the execution of the MOUs. MCPs are required to submit quarterly progress reports to DHCS demonstrating evidence of their good faith effort to execute the MOUs. And then the MCPs are also required to submit the executed MOUs to the department and also publish those on their websites. And with that, I'm going to pass it over to Anna.
Thank you, Amara. And thank you for the partnership as we have explored and trailblazed, I think. I just want to note that CDSS does encourage child welfare agencies to meaningfully engage and collaborate with their managed care plans to negotiate and execute those county child welfare MOUs, just to support the care coordination as managed care plans are increasingly important. And we will be getting a look at how Sacramento County has done that exact work. And I'm excited for y'all to hear from them directly today. And with that, we can jump to that next slide.
Perfect. Thank you. So this slide is really just intended to showcase the executed MOUs that we've received thus far for the managed care plans and the child welfare MOUs. And so this slide just really sort of showcases throughout the state of California some of the executed MOUs that we've received. I do believe that Kaiser did state that they had one sort of hot off the press in Ventura County that was added, I see at the very end. And you can sort of see that this is executed sort of throughout the state. So we have a pretty good variation. As Anna notated, we are really excited to hear from Sacramento and HealthNet and Kaiser today. You can see there's multiple managed care plans that operate in Sacramento County, which makes this memorandum of understanding negotiation a little bit more complex than most. And so we're really excited to have them here today to talk about best practices for how they move forward with executing the MOU. And so with that, I'm actually going to pass it over to Kim Pearson, and we can go to the next slide.
Thank you. So very happy to be here today. Appreciate the invite and our opportunity to be able to share in regards to what worked for Sacramento County with our 4 managed care plans, which, just to reiterate, who we worked with was our partners from Kaiser Permanente and Anthem, and our Molina partners, as well as our, I said HealthNet, Molina, Anthem, and Kaiser. And so through that partnership, just want to talk about a little bit of our best practices that we used, as well as some do's and some don'ts. But before I get to the do's and the don'ts that successfully helped us to execute our MOU, just to level set a little bit. So from a child welfare lens, it's interesting because we know just enough about Medi-Cal to tell you who to call to get the information. So for us in child welfare, we have our point of contacts in regards to when things came up, who to contact. And so taking on this task in regards to meeting with the managed care plans to bring forth this executed MOU, which is an absolute benefit to our children and families, was a really tall task for us. I would like to take a minute to thank DHCS for their webinars, because on my daily walks, that's what I listen to for a good 2 months versus motivating music to keep me going on my walk. So just repetitively listening to the webinars to help guide the work that we would be doing with our 4 managed care plans. So next slide, please. Okay, so these are some do's in regards to how backing us up to even how we got started. And our hope is that for the child welfare jurisdictions who are on the webinar or who happen to watch this webinar, that these do's will be really helpful for you as well as the don'ts. And everyone is at different stages in their journey. And so this is kind of put together to support you in whatever stage you're in regards to MOU execution. So I'm going to start from the very beginning. I'm not going to spend time on each of the do's, but just a little bit to kind of give context to what the successful strategies were that helped us. So the first one is when we first began working with our 4 managed care plans, if you have not heard from your managed care plans, reach out to them if they have yet to reach out to you. That was really important for us, and keeping in mind that our managed care plans, that they have multiple jurisdictions that they are working with. And so, we thought, well, we haven't had the reach out yet, but we know that they're wanting to move forth and work on the MOU. So we did a soft reach out to them. We were able to join one of our behavioral health partners, one of their meetings, and I was able to introduce myself and convey that my team is the lead with executing the MOU. And all 4 managed care plans were present and agreed to move forth with a subsequent meeting. And so that was really kind of the key that kind of helped us to dive off into executing the MOU. I'll say that during that window of time, what was often shared with us is that the managed care plans are the lead in regards to moving forth with executing the MOU. However, when it comes to the initial connection or engagement or doing what's best on behalf of our kids and our community, we weren't really looking at who was a lead and who wasn't. We were just looking at how could we come together to collaborate. And so don't let that piece kind of, if you hear, well, the managed care plans are the lead, and if you haven't heard from them, there is benefit in taking that gentle initiative and reaching out to them. We're very fortunate in our county to be able to work with the managed care plans that we do. Because it was the right move for us. And then as we moved forth, which is our second bullet of do's, we moved forth with a unified team approach. So all the managed care plans meeting together with us as child welfare. So very important. Because, as I stated, in child welfare, this isn't our only assignment, as we know, not the only assignment. And the managed care plans, they also have a number of jurisdictions. And so to be able to streamline the time in which we could come together, that was a decision that we made that worked best for our county, was to hold a unified team managed care approach, managed care plan team child welfare approach. That also allows for being able to ensure that what we identify to put in the MOU, that all the managed care plans are also on the same page. And then I would just say, I won't spend a lot of time on this, but just if you are in a space where you are going to reach out to the managed care plans, and even if you started the work and then maybe you've stopped, that you as child welfare reaching out to reignite that work if that's what is needed. So if that is the case, just be prepared to facilitate the initial meetings if needed, and be able to walk through and set the shared goals. I would say that we met initially and child welfare facilitated those meetings. However, as a collective and as a team, and you're going to hear me say team quite a bit, because I really do feel like the work and the relationships that we have built, we've really become a team who's working together in collaboration. So be prepared, but then once we were able to kind of dial in and discuss our shared goals, then the facilitation and the lead type of work moved over to the managed care plans, which they embraced and moved through. That allowed us to reach a level of success. The next bullet I won't spend a lot of time on, but in walking through the MOU and getting it executed, certainly setting a regular cadence for meetings. That is super duper important, as I think folks know, because everyone has jam-packed schedules. And so being able to have a standard set time is really important, and to be flexible. Both sides have competing schedules. I will say, and I'll talk about this a bit later, for child welfare execution, the way you build your team, or the way you may have been operating previously, and if there's an area where there's some challenges in regards to moving forward, hopefully some of the information I'll share later on can be of support. One of the things we wanted to make certain of is to ensure that there's a note taker in those meetings. So those meetings we try to meet every 2 weeks. We started off meeting every 2 weeks in regards to the execution of the MOU, reviewing the MOU together, and what we, each respective side, wanted to ensure was included in that MOU. And now we have moved on, since we've executed the MOU, we've moved on to meeting every 2 weeks to review our policies and our procedures. And if you'll note, a key word that I said in there is our policies and procedures. And I will touch a bit more on that when I get to that bullet. So we also have, I say ensure that a note taker is present, we also have a tracking log. We met just yesterday as a team of 4 MCPs and the county on our policies and procedures. And a lot of query came up in regards to, is that in our tracking log? Because what the tracking log allows for, and we can share examples of that if jurisdictions would like that tracking log allows us to ensure that the things that we talked about, or any type of follow-up that might be needed, that we know it's either been addressed, we need to go back and give it attention, etc. So really being able to keep ourselves on track and be accountable as we're walking through this multitude of information in the MOU. Of course, you'll want to identify how you and the MCPs as a team, once again, bolded there and underlined, will walk through the MOU. So will you go line by line? Will you use the track changes? What would that look like for the reviews? Once you have a draft, is it a rotation process? Would Kaiser go first and they'd send it to Melina? Those types of things. Very critical to kind of ensure that you're talking about how, as a team, you want to be able to walk through the MOU process together. And then I'm going to share one more bullet, and then I'm going to pause because we are a team and see if any of our MCPs want to comment on the bullets that I've addressed thus far. But the next one is understand and remembering that the MCPs, that they also have counsel, as does child welfare. And so consultation with your county councils takes time. We know it takes time. So for us in child welfare, to help streamline that time, we really kept county council up to date to ensure that they knew where we were at, and that we were able to educate them on the purpose of the MOU and the needs and the purpose and the benefits. I'm going to pause there for a minute and see if there are any of our managed care plans, or Barbara as a child welfare liaison. You'll hear from her later, her and Ola, if there's anything folks would like to add thus far. Okay, I'm going to keep going. The next one was talked about earlier in the presentation around considering the benefits, and this is optional, of including the 2083 alignment, including data sharing and the opportunity to create and build on extended relationships with other child serving agencies. That was important to us as a county, that we included that optional language in our MOU, because it's really an opportunity. As child welfare, we have learned so much from our MCPs about Medi-Cal. And it's our hope that from their end that they've learned about child welfare. And that's the beauty of, going forth with an MOU such as this and the opportunities and benefits for children and families, because other child serving systems are talking to each other, they're learning about each other's systems, and 2083 really gives an opportunity for those relationships to continue to be built. Not only that, but those individuals who are in that meeting, and in Sacramento County, we call our 2083 team our Child, Youth, and Family System of Care. So of course, we have all the required individuals who should be present there, anywhere from our regional development centers to our behavioral health partners to our Sacramento County Office of Education. And so those partnerships are really important to the managed care plans and the overall goal of CalAIM, because those individuals and those entities, they are referral sources as well. So when they understand how things are occurring and what's available and what supports are there, and vice versa, it just builds a stronger MOU. And it's not just we executed an MOU with words on paper. We're actually putting it into action by continuing to build these relationships. Excuse me. So one other thing is, it is really, really critical to discuss upfront, understanding that you're going to need to develop policies and procedures. And so that is part of the requirement. And in the template and the MOU, it speaks to it around that these, the MCPs are responsible for building policies and procedures. Well, you heard me earlier convey we are a team. And so as a team, we decided that we were going to have shared ownership on those policies and procedures. And when I've shared that with other departments who might, be at the pace where they're just kind of getting deeper into the work, one of the concerns that have come up from them is that, well, those are the MCP's policies, so they're not really applying to, or will we be able to have input into the policies and procedures? And the way that we work together, and the section of this presentation is negotiating, right? The way we work together as a team is we really spelled out the need for the shared ownership, so that if there was something that we as the child welfare department felt should be amplified in those shared policies, that there would be opportunity for discussion and to ensure that that information was included. And I shared yesterday that we just had a meeting, and there is a section in the policies and procedures. The team, the MCPs who were on the call yesterday will recall this. There's a section in the policies and procedures, it's in the MOU as well, of course, that speaks to notifying the social worker if there is a refusal of services, or if they're unable to connect with the family. And so we talked about how, from child welfare lens, when we're unable to contact with the family, this will be familiar to child welfare folks, we make several attempts. We make more than 3 attempts, we make 3 attempts, and we do it at varying times. So we wanted that to also kind of mirror in regards to the families that the managed care plans would be servicing, so that it wasn't just they didn't respond, so we're going to close out. And all of the managed care plans were in favor of that occurring. However, it's a matter of operationalizing that, and what is that going to look like? And so, that's kind of like what I guess I would align with the title of this section of the negotiation. Like, yes, we're in favor. We understand, why that needs to be present, but we have to kind of think through how that's going to be able to operate on their end. And so it's that mutual respect of understanding what is critical to child welfare, and then also understanding our respective managed care plans, what their staffing levels look like, and how they will be able to incorporate that into the work on their side. And again, it is, I think, one of the benefits for us in the way that we've held our team approach is, remembering that the managed care plans don't know child welfare. And so sharing that information with them in regards to how we operate and what some of our policies and procedures are, helps to give them the why when you're, trying to think through, like, well, this is important for us to be in the MOU, and they might not be there yet. But when you're able to give the why and you're able to identify language that you're able to compromise and still get the spirit of what you want from child welfare and what fits with the managed care plans, it's a beautiful thing. It is truly a beautiful thing for our kids and families. So really discussing, the other thing I wanted to mention on the policies and procedures is, as you are going through the MOU, and this is what our team did, is really tracking and calling out, because everything in regards to the how-to, which is the purpose for the policies and procedures, everything cannot be included in the MOU as far as, the steps. So really being able to, whether it's track changes or earmark that this is something we are going to expand on in our shared policies and procedures. And so that has worked really, really well for us. And then speaking again to child welfare teams, it was really hard to take on the task, because again, it's a tall task to take on, learning a whole nother system, as well as, we all have, other assignments within child welfare as well. So when you're building your structure, and we've heard this from other jurisdictions, that the staffing resources are pretty limited. And so, don't let that be a deterrent. Leverage your existing staff. So what we did to help support this is we identified at least 2 child welfare liaisons. Barbara Olashe, who you'll hear from shortly, is one, and then Billy Hernandez is our other, to really ensure that whatever it is that we're doing, whether it's a meeting, whether it's follow-up, whatever that need is, there is always someone who is able to be present and working with our managed care partners. That is so critical, because in our world, we know that there's a lot of conflicts that come up. And so, oftentimes conflicts can prevent things from moving on. And so being able to build your team out where folks can cover for one another, that's really going to be beneficial for you being able to move forth and timely execute and go through your MOU. And then lastly, I'll just say, as you're going through your MOU, whatever, it looks like for whatever jurisdiction, planning for training along the way. That is absolutely in the MOU. We're further building that out in our policies and procedures, but it really should be a joint effort to discuss the engagement strategies, including we have 2 of our staff on as well that you're going to hear about, you're going to hear from later, but I'm just going to shout them out right now. Supervisor Aquino Wambar, who is with emergency response, and social worker Jessie Gomez-Coates, who's also with emergency response, because it's really important to recognize staff who refer youth, because this is new to staff as well. And so it's really important that that they, as social workers, are recognized, and they're also able to share that information with their peers. And then don't forget, the internally providing training to partners, public health and other supports. We mentioned the 2083 group, really making sure that they have an understanding of CalAIM, and especially ECM and community supports. And so all of these dues is really what helped us to be able to execute. And most importantly, taking that time to build the relationship with the MCPs, because that is going to support the areas where you do need to negotiate, and building in the why, and then also understanding from a level of mutual respect with one another, why they might be hesitant to have something in, and why we might be hesitant for the way that they might want something to be included as well. And so we were able to successfully execute, and we're going to go to the next slide to talk about some of the don'ts. Next slide. Okay, so the don'ts. So it's going to start with, again, not knowing where folks are at in their journey in regards to executing their MOU, but I spoke about this a little bit on the prior slide. Don't assume if the MCPs have not reached out or there's been a gap that they're not interested. I already shared, and you all know that they have multiple counties, so reaching out can support all involved. And then don't be afraid. I talked about this before, and in child welfare, and as there's a lot of leaders on here, child welfare staff, we tend not to be afraid to call anything out just because of the nature of our roles, right? Working with families. But don't be afraid to call out what is critical to child welfare. I shared this earlier. The MCPs, they may have some knowledge in working with child welfare, but they don't have the knowledge of the day-to-day operation. So taking time to explain the why, it brought forth the further understanding, which led to the inclusion of areas that we wanted to have in the MOU. And then this is one of my favorites, and I think we encountered this yesterday. And as we encounter things, speaking very candidly, we are able to work through them. And so don't get stuck. We could have spent a lot of time yesterday on a particular area where we needed some further offline discussion. But if you need more time to address an area, this is a favorite of mine, think Elmo. Enough, let's move on, right? So just knowing that, let's call it, and if there's a need, it can allow for the respective teams to discuss offline. And then you table that as a to-do, and you put the comments in the track changes, and we come back refreshed, and we've always been able to work through where we need to go next. And then don't forget to build a timeline. And this is in relation to our child welfare internally. We have our work we do with the managed care plans, but we also have our own internal work plan as to when are we going to have a response back from county council, what type of time frame do we need, etc. So that's really important, and don't forget that, because that's going to help streamline and provide answers and responses back in a timely fashion in order to get through your execution. And then don't delay due to decisions outside of the lead team. This is really important and I'm going to give an example within our MOU on data sharing. So we're the MOU that allows for the ability to pivot and consult with council if needed. Because if we had waited, we're still waiting for the decision in regards to if our county is going to enter into the social health information exchange, the SHE. And so that might be a possibility. However, we haven't made that decision yet. And so if we said we were going to wait for that, we would, as I stated before, we'd still be waiting. So what we did is we worded it in our MOU that allowed us the flexibility to be able to, if we decide as a county that we're going to adopt into the SHE, we stated, I'm just going to paraphrase it here. It's on page 11 of our MOU, and it's under the data and information exchange area. And it says, share the minimum necessary data and information to facilitate referrals and coordinate care under this MOU, including any applicable data sharing agreements as needed. So that allowed us to be able to not have to wait for that decision, but to be able to identify it as a need in our shared MOU, and that we may come back to this and pivot as we determine what shared data systems the county might want us to use. So we don't want to get stuck. And then don't try to fit all the details. I talked about this earlier into the MOU, agree to build that out in your shared policies and procedures. And then just a reminder that don't forget to make sure that you earmark the intention in the draft MOU. And then I spoke about this earlier. Don't forget to recognize that you need to use your team and how you build your team from the child welfare lens. I realize there's other individuals on here outside of child welfare, but speaking from the child welfare lens, it could transition to others in regards to building your team. We're also aware that there are some counties and other jurisdictions who had outside facilitation and support to be able to move forth the MOU. We're a county that did not have that. And so we really had to think intentionally and thoughtfully in regards to how we were going to be able to make ourselves available in regards to executing the MOU. Because when we first started, and we first were assigned, it's like, okay, we have to execute the MOU. That's important. But as we learned more, and continue to move on. It's just not executing the MOU. You have your enhanced care management, the ECM, you have your community supports, you have the training elements that come along with it. We have providers in our community who are interested in becoming an ECM provider. And so it's meeting with them to let them know, hey, what do they need to do in order to become an ECM provider? And we even put some attention to that in our MOU, in that if we as the county are able to identify a provider who works consistently with our youth in our community, that they would be given that consideration to each of the managed care plans in regards to being an ECM provider. If, the provider list might be full, et cetera, but really kind of understanding that, we know providers who work with our families and our youth consistently. And so we wanted to give a nod to that in our MOU. And that was a piece that, again, in relation to this section's title, negotiating, that we talked through. And ultimately, it's the MCPs who make the final decision in regards to if they're going to contract. But I think respectfully, the way that we've worked together as a team, that there would be opportunity for dialogue if we had a provider who really we felt needed to work closely with our families as an ECM provider. And then finally, don't forget to keep leadership apprised of the status, progress, and any worries you foresee, and share your draft work. That was super critical for us because, being able to apprise them as we went and share the draft as we went made the final reading of the MOU easy on them, because they were aware and they'd been kept apprised, and it wasn't their first read through. And so that allowed us to really be successful in regards to executing the MOU. And I will say this, that there's a lot more do's and don'ts, but I know that we had limited time. But I will say that a number of these specific areas is really the reason for our success. It was a recipe for our success and working together as a team. And so I had the 2 slides, and I think I saw some chat questions come in along the way. So I see a question from the first one, I think is from Diana. Hi, Diana. Let's see, what advice for the counties that feel their P&Ps need to be done first before the MOU? I would say from and MCPs, if you want to comment on this as well, but I would say that would be a challenge from the experience that we have had as a team, because you need to first agree in regards to what is going to be in the MOU. And so to build out the policies and procedures prior to the MOU, I would be worried that we would omit something, or that there could be a focus area, an area in the P&P that might not essentially make it into the MOU. So I think that MOU, and when you hear from the team shortly, you'll see how that flow went, because really being able to put together an MOU and convey through that MOU language how we will operate. We didn't just want to, again, have words on paper. We really wanted to make sure that what was in the MOU was going to be able to be executed. And you'll see from our MOU that then led to the good work that is happening with our social work teams and the MCPs. So I as the lead manager and working with our MCPs and our child welfare liaisons, it would be difficult to do that. And is that the only question? I think so. Okay, well, we're happy to share any of the documents that I mentioned that helped us. And we're also happy to be a point of contact for any questions that you or your jurisdiction may have. And we appreciate your time.
Thank you, Kim. I think we have Kim Swift up next.
Thank you so much. Good afternoon, everyone. My name is Kim Swift, and I'm really happy to be here today to talk to you a little bit, give you a bit of an overview about the Managed Care Plan Child Welfare Liaison. I know we've touched on it just a bit throughout the presentation so far, but want to give you a little more context and information about it. So next slide, please. Okay, so the main thing we want to focus on is that the managed care plan contract, which DHCS contracts with the managed care plans, requires the managed care plans to have a child welfare liaison. And we were formerly, if you may in some older documents see this referred to as a foster care liaison, however, it's now referred to as the child welfare liaison. That is included in the contract. We, as DHCS, have also developed some additional guidance in the way of an all-plan letter. This all-plan letter is 24-013. And this all-plan letter provides guidance to the MCPs about the roles and responsibilities of that liaison. And we worked pretty closely with CDSS and several stakeholders in the development of this all-plan letter. The main goal of the Child Welfare Liaison is to ensure the coordination of services for members that are children and youth involved in child welfare. We really want to make sure that this population is has a focus and has a main point of contact that way if there's any issues. Next slide, please. Okay, next we want to talk a little bit about the purpose of the liaison. And it's really to ensure that there's someone at the managed care plan that can resolve escalated issues when members are having challenges on any issues that come up. So these liaisons are focused on this unique population. So they are dedicated and have expertise to help resolve issues as they arise. As we know that, there are unique challenges and issues that do come up for different populations such as this. And these liaisons are intended to interact with the staff members that work with the member. They're not intended to be member facing. So some examples of the people who might contact the child welfare liaison at the managed care plan would be the healthcare, the public health nurses, social workers, ECM lead care managers, any other person that interacts with the member that really needs assistance to get the member services, connect with providers, and that sort of thing. Next slide, please. Okay, I also wanted to highlight, kind of at a higher level, just some of the requirements that we have provided for this liaison. So for staffing, managed care plans are required to ensure that they have the appropriate level of staff to ensure that they can serve this population for their service area. So this might vary county to county. Some counties that are larger and have a larger number of members that are served, especially in this population, might have more liaisons, whereas smaller counties, more rural counties, they might have one liaison, or larger ones might have two. It just depends on the need and how many calls they're getting and that sort of thing. So you'll see that that vary on the contact lists. We also think it's important to note that the person serving this role should have expertise, experience, and or training on certain topics. So the certain topics that we included in our requirements is child welfare services, obviously, and county behavioral health services is really key components to really make sure that the services are well coordinated and to resolve issues. Care coordination and assessment processes are also really important to ensure that their care is well coordinated. And then really wanted to highlight that we've included trauma-informed care practices for this population to ensure that, that's taken into account as they're moving through the process. Next slide, please. Okay, this slide we've provided a little more detail on the individual roles and responsibilities that we've highlighted within the all plan letter. I won't necessarily read through each one of these, but wanted to highlight some of the big ones. I already mentioned resolving escalated issues. That's kind of the main big task for this liaison. We also expect the liaisons act as a resource within the managed care plan to provide assistance to their staff and to coordinate care for members. So they may work with other areas of their plan to help with navigating services. They'd also assist with navigating just the managed care plan system and coordinating services throughout their area. So that might include various services that are available, even if they're not available in the plan. They can also work with other managed care plan liaisons at the plan level for other topics. So highlighting here the tribal liaison may be a good link in for child welfare for those individuals that fit in that category. And then also we want to highlight that this role will also support ECM referrals. So anytime a member has issues, this might be a good link in for enhanced care management, getting them connected whenever that's appropriate. And then the last thing I want to highlight here is that we do expect that with all this expertise and knowledge and work, especially the good work that we're hearing going on currently with policies and procedures, coming up with different processes, maybe process improvements, we really want to ensure that these liaisons are tied in with the plan's quality improvement, so that we can make sure that any areas where it's frequent issues are coming up, ways that processes can be improved, they're really plugged into that process to help kind of gain efficiencies and that sort of thing overall. So we wanted to highlight that as well. Next slide, please. Okay, so that's kind of the high level for the liaison. But what we really want to think is really valuable here is to hear from you all more about on the ground. How's it actually going? So I want to kind of hand it off to our partners at Kaiser Health Plan, who are going to share some best practices for child welfare liaison and county collaboration. I can't wait to hear what you have to say, so I'll pass it over to you, Kaiser, to introduce yourselves. Thank you.
Hello,
Hi, good
everyone.
afternoon.
Go ahead.
I'm sorry.
Hi, hello everyone. My name is Love Melnichuk, and I'm the Child Welfare MOU Contract Manager with Kaiser Permanente, and I would like to go on the next slide so we can start our presentation. We're going to do a really quick collaboration presentation with HealthNet and also Sacramento County, and these are going to be all the speakers. I'm really excited to be here, and I had the pleasure and honor to meet a lot of you during our MOU conversations and negotiations, so super happy to be here. Let's go on to the next slide and we'll go through them really quickly because I want to leave the most time for our child welfare liaison, Ola, to speak. Let's skip the agenda as well. Let's go to the next one because we don't have a lot of time left. Our first thing that I'm going to cover is our MOU work group and execution. Next slide, please. For Kaiser Permanente, we come as a triad. As you can see, my name is Love Melnichuk. I'm the MOU contract manager, and I'm the one that leads the MOU red lines, negotiation, execution, and everything that comes to the MOU executing. Then we have Emily Arianza. She's our MOU coordinator, and she's the one that leads the policy and procedures and the implementation of the MOU. And then we're going to have Ola, our child welfare liaison. And then we have Charlotte as well. She's our second child welfare liaison, and Ola will speak more to the work that she's been doing with Sacramento County, which has been absolutely amazing. Let's go on to the next slide. This is our MOU execution process that we have been going through with the Sacramento County and other counties as well. Kaiser specifically, we are in 32 counties going on to 33 in 2027. Our very first phase one of the redlining MOU is our kickoff meeting with the county. Then we go with the MCPs in the counties to review the MOU template and then the edits. Our biggest thing that I want to highlight that we do want to make all the MOUs as universal as possible across the state, but we also understand that every county is different. So we really want to honor county specific needs, which we usually reserve for the policy and procedures, but there are a few things that some of the counties want to keep for the MOU, and we try to honor that in most cases. As Kim Pearson, she mentioned that it's really important for us to have meetings on the books, but again, we understand that every county is different. For some counties, we meet biweekly, with others monthly, sometimes ad hoc meetings. Some of the MOU negotiations happen through email, so it really depends on every county. So we really wanted to highlight that MCPs in county we track, we consolidate and distribute the red lines, and then MCPs prepare the MOU for the signature. Phase two is the signing of the MOU. The final red lines are being sent to legal teams of both ends, the county and the MCPs as well. Then the legal approval is obtained. Then the MOU is signed by county and MCP. Again, the order varies from county by county. Some counties want to sign it first. Sometimes the MCP sign it first. Totally up to the county. And then the fully executed MOU is filed with DHCS by the MCPs. And then phase three is the execution and implementation of the MOU. That's when the MCP and county develop collaborative policy procedures, which Kim spoke to, and then Emily, our coordinator, she's going to speak more to that. Then MCPs participate in AB 2083 quarterly meeting with Sacramento County. We have been attending those. Those are in person with Sacramento County. Some other counties have it via team meeting or Zoom meeting. Again, it varies county by county. In those meetings, we share ECM and CS enrollment data for our county specifically that we have. And then annual MOU review is conducting approximately about 1 year post-execution. For Sacramento County, we executed the MOU in June. So in about May or June of next year, we are going to be doing that annual review, and that's going to be for every MOU that we sign. Next slide, please. And then the next is going to be Emily Arianza, our coordinator. She's going to speak more to the MOU implementation process.
Hey, thank you, Love. Good afternoon, everyone. My name is Emily Arianza. I'm the MOU coordinator at Kaiser Permanente. My role is to support implementation and day-to-day operationalization of our bespoke MOUs once they move from agreement to action. So what I'll walk through over the next few slides is how we ensure that each finalized MOU is translated into clear processes, shared understanding, and effective collaboration with our county partners. So for this slide, with the MOU implementation process overview, it's really a high-level overview of the MOU implementation process. Once the MOU is fully executed, our focus shifts from contract execution to implementation, and responsibility transitions from contract manager to the MOU coordinators assigned to the specific counties. And just want to highlight that there are 3 essential steps as we move through to support the smooth transition from agreement to operations. So first, we have the execution of the MOU, next delivery of county-specific training, and finally, establishment of the operational processes that really guides us for the daily coordination. And together, these steps ensures that the MOU is not just a signed document, but more of a practical framework that really supports consistent, compliant, and collaborative work with our county partners. And next slide. In the next slides, I'll walk through a high-level overview of the MOU training materials and operational guidelines that really supports this effort. So, I don't know why it says WIC in there. Is that? Oh, here we go. This is just an example. So for our MOU training deck, following the execution at Kaiser Permanente, the MOU coordinator distributes the county-specific training deck within 60 working days. in areas and counties where MCP partners are present, such as in Sacramento County. We do work collaboratively with MCPs to develop the consolidated training and education deck. In this case, we've shared that with Sacramento County DCFAS after the MOU was executed. And the training deck provides a foundational understanding of Medi-Cal MCP services, and it highlights the key programs and most relevant to our MOU partners. That's including eligibility, benefits, your complex care management, CalAIM. And it really ensures that all partners begin implementation with a shared baseline of knowledge. And the next slide, please. All right. For our joint MOU policy and procedure, of course, after we send the training deck delivered to our county partners or third-party entities, our MOU team collaborates with our county partners or third-party entities, along with our internal key stakeholders to develop the joint policy and procedure. This document really serves as their formal operating framework, which outlines roles, responsibilities, step-by-step processes that support consistent care coordination, referrals, including data sharing. It also details how the parties collectively comply with Medi-Cal for kids and teens, geriatric services, and any applicable regulatory requirements, including the APL 23-029. And I'll highlight that in Sacramento County, we are fortunate to really have a strong and collaborative partnership with DCFAS and our other MCP partners. And as Kim mentioned, we've been dedicating focused time to reviewing the child welfare MOU policies and procedure to really ensure that the requirements outlined in the agreed upon MOU are realistic, operationally feasible, and clearly understood. And to support this effort, as mentioned, we've established that meeting cadence to walk through that PMP process biweekly and documenting, aligning our expectation and addressing any operational considerations in real time. And because this policy and procedure is a living document, we also have, again, the flexibility, as Kim already also mentioned, as organizational changes occur or a new regulatory guidance is issued. Want to highlight that HealthNet, and Vernell will be speaking to this, has generously provided a centralized platform through Transform Health, which really serves as our shared repository and allows partners to collaborate and make real-time updates to the joint MOU policies and procedure. So with that, I'd like to transition to Vernell, who will share more about Transform Health, its acquisition, purpose, and how it supports our collaborative MOU PNP process. So
Yes,
Vernell, take it away.
you. Thank you, Emily, and good afternoon, everyone. My name is Vernell Shaw III, Senior Director, Northern California Medi-Cal Regional Lead with HealthNet, also supporting much of the strategic MOU work internally for HealthNet. I appreciate the opportunity to be here today, speak with you a little bit about the joint PMP document hub. I know we're running tight on time, so I will be as brief as I can. What is the Joint Policy and Procedure Document Hub? So it is a collaborative online hub for joint policy and procedure negotiation, tracking, storage. It's built on a Microsoft 360 SharePoint-based platform, and it offers county-specific landing pages and MOU-specific folders in which the collaborative work occurs and is stored. It ensures version control, secure encrypted access with multi-factor authentication, and tracks all document activities by user. The hub simply aims to make the negotiation of the PMPs secure and easy for all parties. A little background about how and why HealthNet decided to kind of go in this direction. As Emily said, like the MOU, once fully executed, mostly becomes a static document and likely won't require many, if any, updates, amendments, or changes, whereas the joint PMP is more of a living and breathing document, right, that will evolve over time. There will likely be regular updates or changes based on either regulatory changes or changes that occur at the local level. For example, something as simple as the need to go in and update names and or contact information as a result of staffing changes at the local level within county departments or at the MCPs. So given the sheer volume of MOUs that are now required for execution and considering the commensurate number of joint PMPs that will also need to be completed, the HealthNet MOU team and leaders began thinking, like, how are we going to do this, right? Like, how are we going to create, collaboratively negotiate, track, update, and store these joint PMP documents across multiple counties and with various county agencies, all while endeavoring to effectively manage version control, right? So our solution was to strategically partner and contract with a reputable, neutral third party that had experience supporting Medi-Cal projects and initiatives and a track record for successful collaboration with health plans and county agencies. And so we decided to contract with Transform Health. Some of you here today may be familiar with Transform Health, but for those of you who are not, Transform Health is a nationally certified minority and women-owned health policy consulting firm focused on customizing solutions that improve quality of care and health outcomes. So Transform Health partnered with the HealthNet MOU team and leads to develop and host, and more importantly, really host the Document Hub as a resource for joint PMP collaboration in HealthNet counties. And though HealthNet is funding the resource, we extended the usage of the hub to plan partners in all HealthNet service areas. We also invited several county partners and several plan partners to user test the platform and provide feedback prior to it going live. So as of today, the Sacramento County Department of Child Welfare and Adult Services, as well as all of the Sac County MCPs, as Kim and Emily mentioned, all now have individual access credentials. Everyone has been trained on the hub's functionality and best practices, and everyone is actively in that environment, collaboratively working to negotiate and complete our joint policy and procedure for child welfare services. Now, I know that everyone on this call isn't necessarily from a county where HealthNet is operational. So lastly, and really quickly, I'll say for anyone who is interested in learning more about this solution, this resource, I will drop my information in the chat. You're welcome to reach out to me. I think we also might have some of our Transform Health partners on the webinar today as well. So Transform Health partners, I encourage you to put your information in the chat as well, so that any health plan partner or county child welfare partner on this webinar who is interested in exploring this resource, possibly getting a demo, could reach out for support with that. And that's it in a nutshell. I want to reserve time to pass it on to Ola so that she can talk to you more about the child welfare liaison.
Sorry,
Thank you.
sorry to interrupt. And there is a couple of slides just to show illustration of what the Transform Health. So we didn't get to move this slide.
Oh yeah, you know what? I thought that this might have been the only slide. Yeah, so this provides a little more information, or just some information that I've already covered, and I think the next slide is just a screenshot of what the Sacramento County landing page looks like within that environment. So you can go to the next slide. Next, okay. Yeah, so yeah, that's just a screenshot of what the landing page looks like for Sacramento County and the Sacramento County Child Welfare Services folder. Thank you. Ola, I think you're up next.
Yes, thank you, Vernell. Thank you, Emily. Just wanted to say hello to everybody. Happy Friday. We can move to the next slide. Well, actually, can we move back 1 second? Sorry, we're going to go through introductions first. So I will first introducing myself. My name is Ola Ajibola-Stott. I am one of the child welfare liaisons for Kaiser. We do have two. We've doubled in the last few months. So I'll share with you all how to access us or how to get a hold of us in just a few minutes. But I wanted to pass it over to Barbara to introduce herself as well.
Good afternoon, everybody. My name is Barbara Olashea. I'm with Sacramento County Department of Child, Family, and Adult Services, and I am the county liaison for our managed care plans.
I wanted to welcome Aquilino to come and say hello.
Hello, my name is Aquilino Wamba. I'm a Sacramento County supervisor, Supervisor Jesse, and I get a chance to work with the team in one case a few months ago.
Also going to invite Jesse to come off mute to say hello and to introduce himself.
Hi, my name's Jesse Gomez Coates, and I'm an emergency response social worker with Sacramento County.
Thank you so much. And so the four of us will be presenting this next section of the presentation. If we can go to the next slide. So Barbara and I are going to talk about our collaboration thus far as relates to the MOU. So we bucketed this into three different puzzle pieces. We first are starting off with our local engagement. As far as the local engagement, I will start off by talking about our MOU. I know you guys have heard a lot about our MOU conversations already, but both Barbara and I, as the child welfare liaisons, Barbara on the county side and myself on the MCP side, are on every single MOU conversation to redline during the conversations of redlining, and also we're at the table for our PMP conversations. And so we bring the subject matter expertise to the table, and we understand the workflows behind the scenes. And so that is all considered as we work on our MOU pre and post execution. Barbie, do you want to talk about our CalAIM?
Yeah, absolutely. And then also another opportunity for engagement has been on we're calling it roadshows, the CalAIM roadshows and trainings. This has been an opportunity to bring in all four managed care plans to help with the planning and the facilitation of those trainings, along with our CalAIM consultant, Baljit Handal with Child and Family Policy Institute of California. In fact, last year we did, I think it was about 8 sessions and trained about 200 staff on a CalAIM. And that was actually done prior to the MOU execution because we realized that it was taking quite a while as we were developing the MOU, but realized that we do need to educate our teams, our staff on this much needed services that our children and families qualify for. So that joint was trainings were done in person throughout our department. We really wanted to make sure we targeted the right staff. So we focused it on our social workers who are actually working with the families. So that was throughout the continuum of care of child welfare, as well as our public health nurses who are involved in working alongside with the social workers. And
Next,
then
I'll
we'll talk
talk
about the next
about
slide.
our monthly strategy calls. And so for those who are not familiar, Kaiser does have a network lead entity model. So we have Full Circle Network that is taking on all of our ECM enrollments for our child welfare population. And so we, myself and Barbara, have been meeting with Full Circle Network monthly for over a year. So a lot of discussions on how do we get the information out there to the frontline staff, as well as what types of populations within the child welfare continuum we like to focus in on initially to start, and if there's any type of pilots we'd like to implement at the department level. So we had one where we looked at safe measures, some of those youth that are difficult to place. That's one of the populations that we took a look at last year to see if we can engage ECM as a support service for those youth.
Another opportunity for engagement, as many of the folks have already mentioned, is the Child and Youth System of Care, the AB 2083. Our managed care plans have agreed to participate on a quarterly basis. That's an in-person. This is an opportunity to share trends, provide timely updates and resources, and contribute to coordination and collaboration efforts. Managed care plans do share data at this point. And it is also really to understand this is a shared effort to understand and align the county's whole person and no wrong door work that the system of care is already doing. This is also an opportunity for the system of care team to really kind of think about, this is bigger than just training our staff on enhanced care management, but that there are other departments that are involved in these meetings and partners who are really integral and in that part of referral and linkage efforts to those children and youth population.
And lastly, I'm going to speak to a few pilots that we've been engaging and collaborating on. We do have our social media pilot that I will give a shout out to our local engagement team that's been led by our Vanessa Davis, as well as for Sacramento County, Christina Pena. So a lot of work with just giving a lens of support, or giving a lens of how ECM can impact foster parents as well as anyone that's involved in the child welfare system. And also, those might be aware at the Sacramento level that we have an amazing child abuse pediatrician, Dr. Michelle Evans. We've engaged Dr. Evans probably about 2 years ago with just really wrapping our hands around the youth that are presenting on her suspected child abuse and neglect case calls to see if we can engage ECM early on to further prevent out-of-home placement or to engage with those foster youth that are already in out-of-home placement. So that was a huge success. I wanted to mention, as Barbara was mentioning, the AB 2083 calls, we did see a lot of jumps in our child welfare population of focus based off of the work that Dr. Evans and team is doing. And then I'll move us into the next puzzle piece, which is issue resolution. We won't go through all of them, but I wanted to highlight a few. I will highlight Bright Futures. So one of the nature of our role, myself and Barbara, is working through issues or escalations. And so one of the ones I wanted to highlight is I know that we have the Bright Futures periodicity issues that have come across our way. And so that's one thing that we typically will help navigate those appointments. Internally for us, for Kaiser, we based off of hearing from our county partners, specifically Sacramento and other counties, is that our youth do need these placement exams. So when they're placed in foster care, they have to be seen within 30 days. And so we needed to ensure that our internal medical group partners understood this requirement, and so we engaged a workflow that is now addressing those needs.
Another issue that has come to our attention is like drop in Medi-Cal coverage and exploring as to what happened and what's going on. For example, we had some children who were adopted out, and once that adoption is finalized, it appeared on the managed care side that they had been dropped from coverage, but when really their Medi-Cal client index number had changed because now they are part of a new family. So just being there and available to help look that up and check that information out was really helpful. And I'm also going to skip down to care team lookup. So that really kind of aligns with almost that same line, is when our managed care plans know that this is child welfare involved youth or child, who is the assigned social worker, so we can help link the social worker up to help coordinate that effort.
Thank you, Barbara. And then I'll just speak a little bit towards AB 220. I know that's a hot topic with our child welfare agencies. And so that's one that, through our connection with Sacramento County and other counties, we were able to get some public health nurses to inform some of our medical group partners on the intent of the JB 220 and the need for the JB 220. And so we have been able to look at workflows that would ensure that the county is getting these forms signed in a reasonable amount of time. And then I'm going to skip over the care coordination because I think what we'll do is we'll talk about that in our member story. But essentially, both Barbara and I are the liaisons, and we want to ensure that our youth are getting the care coordination that they need. And I want to make a note that both our Kaiser Child Welfare inbox is noted there, and also DCFAS's inbox is there as well. Next slide. All right, so here's where myself, Jesse, and Aquilino will start to move through this member journey. And this is something that we worked on together through our collaboration and the introductions made through the MOU. But just a little bit of a story in brief. This is an infant with a history of serious brain injury, presence of a G-tube, global developmental delay, and severe protein and malnutrition. When we did get this family, she did have a poor prognosis and was on hospice. I also wanted to mention that this was a referral that was made internally from our child abuse pediatrician and her team. And so walking along this journey, I'm going to first start with the ECM education and enrollment. So our actual child abuse, it's called CASP, Child Abuse Services Prevention Program. They were able to provide not only the county, so Jesse and Aquilino, as well as with the family, education on what ECM is and how it can support the needs of this family. So I wanted to invite Jesse to kind of speak to, what that experience was and how that learning about a new service, how that was for you.
So when I worked with the family and I had a consultation with Dr. Evans, she educated me about the program ECM and a program where the family could be linked with a case manager and the family could be linked to additional resources and everything streamlined and the family followed by this case manager. So I spoke with the mother about it. She was agreeable, and Kaiser reached out to her. There was a social worker with Kaiser Roseville that reached out, obtained the consents. Mom was agreeable to the services, and we had a joint visit with the agency, Koinonia, and we had a meeting with mom. It was really successful. Mom allowed me to discuss what brought us involved or why we got involved with her family and the worries that the department had and the referrals made for the family and how Koinonia, the case manager within that agency, could follow the family. So mom wanted to continue on with services. Our department assessed that the risks have been alleviated or mitigated and that we could close out. And so that was the warm handoff to Koinonia.
Thank you, Jesse. So essentially, we started off with an initial case call. Typically, during that initial case call, we have, if there's CPS involvement, we have the CPS social worker. We have our CAFS team, which is the pediatrician and social worker. I am there as well, and any other supportive services that might be engaged at the time. We talk about the family's needs. Ensure that the lead care manager has the most recent information on the family as far as their demographics and where they are. And then we share contact information and then schedule a follow-up for after the care plan has been completed. And so I wanted to highlight that this was a family that Jesse offered to do a warm introduction in person to the family so that the family felt comfortable with, another person coming in and continuing to provide services for that family. And then, Jesse talked about how, they felt comfortable with, the fact that ECM was now engaged in closing the referral. But in the meantime, there were, I'm at the fourth bullet there, there were ECM service coordination needs identified, which were housing, regional center, transportation, IHSS, and CalFresh and WIC. And then we see that there was that case closure that Jesse talked about. And then, unfortunately, and we don't like to, hear these outcomes, but our youth did pass away in her sleep overnight, and it was suspected to be related to her medical conditions. As I mentioned, that she had a poor prognosis. And so I want to just pass it over to Jesse to talk about the cross-functional team notification, because the same day that youth passed away or the infant passed away, the Kaiser team was alerted within a few hours, so we were able to pivot.
So I was contacted by the Sacramento County Coroner's Office. They had questions surrounding the family's child welfare history that was provided to them. And shortly thereafter, I notified the medical social worker over at Kaiser Roseville as to what happened with the child passing away.
Thank you, Jesse. And I wanted to just share just some of because of that fast response from the department, we did get on a call the same day with Koinonia, who was able to swiftly provide a safety net for the grieving mother and her kids that were living in the hotel. And so they were able to provide some financial assistance in the moment, as well as they dropped off gifts and clothes and toys for the family. And that was within a week because of the fast and quick notification to our teams. And then, knowing that this was an unforeseen and an unfortunate situation, we definitely wanted to make sure that the care teams knew that this did occur, just so that we were, we were trauma informed and being able to, and we weren't further harming the family without knowing the news. So then our last bullet here was just the continued support. I want to just open the space real quickly for Aquilina and Jesse, just because I know that some of the one of the hardships that we learn about with engaging ECM into a family that's already child welfare involved is that there's a lot of people at the table. I wanted to just welcome Aquilina and Jesse just to speak to how that felt as to adding a new support in the home prior to case closure.
Well, I'll go first quickly. So JC already said a lot, and you guys just said a lot about the process. So me as a supervisor, when the referral came into us, it was labeled as severe neglect. The parents and mom is not able to provide adequate care and meeting the kid's medical need. So it's already labeled as a complex case with a high risk. Um, so there were a lot of worries. Um, what level of intervention that CPS could use to work with the family. But the partnership we have with you guys made it much easier for me as a supervisor to work with Jesse and also my program manager because the case was labeled as high risk and as severe neglect. So the weekly meetings we had with you, Ola and her team and Dr. Evans later on, really facilitated the process. And I was very pleased with the outcome. And in the meetings we had, JC was able to go out there and meet with family and then come back, update me. And then during the meetings, we update them. So as case grow and we see progress, we realize that the initial concerns were not just mom's failure to provide the adequate care, supervision, and meeting the kids' medical needs. We find out that there were some issues that moms dealing with housing, domestic violence, a lot of stuff. And referrals were made and on time. Um, we followed up and we were able to close with the case, even though it was a high risk. We know that our partners can continue providing the supports the mom need and for the baby even though the outcome was not what we're expecting, but we know that this is a very complex case with a kid with a lot of medical issues. And just get that the last update from the coroner's office, he follow up and updated the team. So from here, I'll transition to Jesse, and then again, I just want to say I'm very happy this program exists, allows us to work together and meet the family's needs.
So, with regard to the collaboration, that was really great. Once Dr. Evans made the referral and we started having the meetings, there were multiple meetings with the team involving myself, my supervisor, Dr. Evans, you, Ola, and other Kaiser staff persons. And we addressed the family's needs. Koinonia was also there. And we figured that the referrals for the family to address housing, which our department referred the family to bringing families home. We made a referral for the mother to have domestic violence counseling, and mom agreed to the ongoing case management services from Koinonia. And she was pleased that the department could close out, and she was also pleased that everything would be streamlined and followed with the support and case management from Koinonia.
Thank you, Jesse. Thank you, Aquilino. And thank you for your partnership. It was great working with you with this family. I know we're almost at time. I just wanted to share a quick note from Dr. Michelle Evans, who's our child abuse pediatrician. On behalf of the North Valley Kaiser Permanente Child Abuse Services Prevention Program, I'd like to extend a heartfelt appreciation to Sacramento County's Jesse Gomez Coates and his supervisor Aquilino Lombard for their exceptional contributions and unwavering commitment to collaborative care. And I also want to mention that she also gave a special shout out and thanks to our Koinonia team, who was very quick to respond and to today is still giving the family support. So I wanted to thank all the teams. And I did see a message in the chat that it is pivotal to have all the different multidisciplinary teams working together. And this was just a testament of that. Real quickly, Barbara and I are going to walk through these best practices. Barbara, you have the first one.
Oh, yeah. So, I mean, you guys can read it. It's right up there. How important it is to offer and provide that training or road shows out to your staff and teams on the child welfare side, because it's really important for them to know what services are available and ongoing. I think that's also it's going to be really key for our agency anyway. We do see lots of movement of staffing, and so really making sure that we are keeping them abreast of the information.
And then I would say for child welfare liaisons, one of the things I've been really working on is when I do get escalations from the county, whether it be the public health nurse or the social worker, I look for opportunities for that youth to engage in ECM or CCM.
And consider monthly touch points with your county liaison. So that would be me. But I guess like on the other side, also for us as a county with our managed care plans, liaisons as well, really talking through care coordination enrollment strategies. Now for Sacramento County, we have 4 managed care plans. And so even whatever work we might be doing with one specific, we're really ensuring that that is being, sorry, that is also that what we're doing is really going to help with all members, no matter what managed care plan they might be part of.
Thank you, Barbara. And then lastly, just, one of the successes that we found within ECM enrollment is those care coordination calls. We know that our youth move frequently, and sometimes MCPs, we have the incorrect information on these families. And so ensuring that we are connecting with the case carrying social worker or public health nurse is very important to start and then also going forward. And that concludes our portion of the presentation.
Okay, thank you, Ola. And Ellie, you can go ahead and stop screen sharing, please. All right. Well, unfortunately, we probably don't have enough time to do a live Q&A, but I did share an email link there in chat earlier that if there's anything that came up for you for this presentation and you need some additional clarification, please feel free to send that email to cwshealth@dss.ca.gov. I'll also be updating the slide deck today to add a lot of these links that are shared in our chat. But I just want to send or give a big thank you to our presenters and our participants for today, for your time for this afternoon and being here. We hope that you found some information that's valuable in your work that was shared in this information that you can take into your work and into your practice. Thank you as well. I want to echo, I think Kim said in the chat about just the spirit of the MOU in action, right? And the amazing work teams. And so I want to thank our agency presenters and our MCP presenters and our county presenters, because I think also amazing teamwork happened to get this webinar up for everybody. So thank you all again. It was a pleasure hearing the passion and the great work you are doing on the MOU. And with that, I want to be respectful of everybody's time. If you could hang on for the last couple minutes and maybe fill out our webinar evaluation, that information would be super helpful for us. There is a question there about what you would like to see next. And so if you have any additional ideas on how, additional topics that would be helpful for this Medi-Cal webinar series, we would love to hear from you. Otherwise, thank you again for being here. I hope you have a great rest of your afternoon and a wonderful 3-day weekend.